Kia ora and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners, the Auckland faculty. I'm Dr. Louise Kugler, and today I welcome back to the podcast Dr. Cheryl Buhay to discuss the psychiatric aspects of Parkinson's disease. Cheryl is a fellow of the Royal Australian and New Zealand College of Psychiatrists and is an honorary senior lecturer with the University of Auckland. She is a primary care liaison psychiatrist with Te Whatu Ora Waitemata's Specialist Mental Health Services, providing specialist advice to GPs in the district. She is also involved in GP teaching and supervision and is a contributor to the Auckland Regional Health Pathways. Kia ora, Cheryl, and welcome to the podcast.
Kia ora, Louise. Thank you for having me, and to all those listening to the podcast, hope you are all keeping well.
Thank you, Cheryl. So I wonder if we can just start with a brief recap on how we define Parkinson's disease, please.
Parkinson's disease is a progressive degenerative neurological disorder that involves the dopamine-producing neurons in the substantia nigra in our brain. So Parkinson's is relatively common. There's approximately 1 in 500 people that have this condition. It becomes more common with older age groups. It is believed that 1% of people above the age of 60 have Parkinson's. The average age at diagnosis is around 59 years. And in New Zealand, there are over 12,000 people with Parkinson's disease, and the numbers are expected to increase significantly over the coming years.
So thinking about how Parkinson's disease is characterized, can you talk us through this, thinking probably around motor and non-motor symptoms?
Parkinson's disease is a clinical diagnosis, and it's characterized by the presence of bradykinesia and either resting tremor or rigidity. There are other motor symptoms found in Parkinson's disease, and these include postural instability, festinating gait, micrographia, masked facies, retropulsion, which is the loss of balance in the backwards direction, and hypophonic or soft speech. Non-motor symptoms of Parkinson's disease include constipation, autonomic dysfunction, impaired olfaction. There's dementia, depression, sleep disorders, impulse control disorders, and psychosis, which we will be talking about a little bit later on.
So Parkinson's disease follows a progressive course. I wonder if we can talk about this for a moment.
Disease progression of Parkinson's disease has been conceptualized into 4 stages. One is the diagnosis, where you get bradykinesia, rigidity, and tremor. There's the maintenance stage, where you can get cognitive impairment, postural hypotension, urinary symptoms, and pain. There is a complex stage, where the transition to the complex phase is characterized by increase in motor symptoms. And during this phase, you can have motor fluctuations and dyskinesia. Then you have the palliative stage, where you tend to have more falls, dysphagia, and the person may require multidisciplinary team input. It is also important to recognize that there is a prodromal phase where you can have non-motor symptoms like anosmia or lack of smell, constipation, and rapid eye movement, sleep behavior disorders, which may predict the development of motor Parkinson's disease. The progression of Parkinson's disease is heterogeneous, and it's generally more rapid in those with older age and more severe motor impairment at the onset.
Thinking about treatments, can we talk through the classes of medical treatment and the potential adverse effects, particularly those that affect the psychomotor system, please, Cheryl?
So there are several drug classes used to treat Parkinson's disease, and these have their own set of mental health adverse effects. So you have firstly your dopamine precursors, such as your levodopa, and this is associated with motor fluctuations and dyskinesia. Then you have the dopamine agonists. So examples of these are pramipexole, ropinirole, bromocriptine, pergolide. These agents can lead to hallucinations developing and also impulse control disorders. Then you have the COMT inhibitors, such as entacapone and tolcapone, and your monoamine oxidase B inhibitors, such as selegiline. And these medications can lead to dyskinesias. The monoamine oxidase B inhibitors can also contribute to mood changes. Anticholinergic medications like benztropine are not routinely used due to the risk of cognitive impairment.
What percentage, Cheryl, of patients living with Parkinson's disease will have a psychiatric comorbidity?
So psychiatric comorbidity is quite common in those with Parkinson's disease. So roughly 25% will experience major depression, and a further 25% will have a milder depression. Around 25% will have an anxiety disorder of some sort, and 25% will develop a psychotic disorder. So psychosis, dementia, and delirium, they're more prevalent in the later stages of illness, whereas depression and anxiety can occur at any time.
You've mentioned depression. I wonder if we can talk about the treatment recommendations for depression and Parkinson's disease.
So depression and Parkinson's disease, it predicts greater cognitive decline and deterioration in functioning and progression of motor symptoms. Likewise, pre-existing dementia is a risk factor for the development of depression. The treatments we use for Parkinson's, like dopamine agonists, when you withdraw these, it can also lead to depression developing. And in terms of diagnosing depression in those with Parkinson's disease, this can be difficult because features such as retardation, unreactive facial expression or amemia, anergia, sleep problems, and weight loss do not reliably specify depression. Going now to the treatment recommendations for depression and Parkinson's disease. Firstly, it is important to include and treat organic causes like hypothyroidism, which is common in Parkinson's disease. When you're looking at treatment options for depression, SSRIs are considered first line. Venlafaxine, which is an SNRI, may have some benefit, but it can worsen motor symptoms in Parkinson's. Do consider psychological treatments for depression, such as cognitive behavioral therapy. In terms of tricyclic antidepressants, these are generally poorly tolerated because of anticholinergic and alpha blocking effects. You can also consider augmenting with a dopamine agonist or releaser, such as pramipexole, but you have to be careful though, because it can increase the risk of the person developing impulse control disorder or psychosis. If these agents have not been effective, your SSRIs, then you would follow other treatment options as per the hard to treat depression guidelines. Don't forget to consider ECT, which can be used in the context of depression and Parkinson's disease. But you need to be careful because you might induce a delirium, especially if the person has a pre-existing cognitive impairment.
So psychosis frequently coexists with dementia and Parkinson's disease. Is it the disease process that's problematic, or is it the medications?
So psychosis in Parkinson's disease, it has been linked to the disease process itself, as well as the medications used to treat Parkinson's, like your dopamine agonists and anticholinergics. Psychotic features typically arise later in the disease, so it can be 10 or more years after the initial diagnosis. And it's usually present first in the context of a clear sensorium and with the person still having insight. Wanted to mention some features of psychosis in Parkinson's disease, which may be of interest. These can include hallucinations, which are usually brief, and they're more common at night, in low light, or in instances of compromised vision. So psychosis in Parkinson's can present as visual hallucinations. These visual hallucinations can be simple or well-formed, and they often consist of people or animals, and the content is frequently recurrent. You can get auditory hallucinations, which are often vague or consist of music or sounds, such as footsteps, for example, or whispering. And you can also get hallucinations of other modalities. However, these are less common. So your olfactory, gustatory, and somatic hallucinations. I found it's interesting that you can also have in Parkinson's what they call presence hallucinations. which is when there is a false sense of presence, like a sensation that somebody is nearby when nobody is actually there, or there's a presence that is perceived to be human or an animal, generally in the same room as the patient.
So, how do we investigate and manage psychosis in the community with a patient with Parkinson's disease?
It's important if someone has psychosis in the context of Parkinson's disease, do liaise with neurology and mental health services, obtain their advice around management. If you see this person in your practice, do a delirium screen to exclude potential organic causes. Work on optimizing the environment to maximize their orientation and minimize problems due to poor caregiver-patient interactions. If the person has insight and they have hallucinations, but these are not frequent and don't bother them, the guidelines say you do not need to treat these symptoms. But if you need to adjust medications, you consider reducing or stopping anticholinergics and dopamine agonists. However, you have to monitor for signs of motor deterioration and be prepared to restart these again or adjust the dose to achieve the best balance between controlling the psychotic symptoms and also giving them the best mobility possible. If you are looking at antipsychotic treatments, you can try an atypical antipsychotic. Low-dose quetiapine is best tolerated. Other options include clozapine. However, if you're considering clozapine, you'll be needing specialist mental health input anyway. And for Parkinson's disease psychosis, clozapine doses are very low. So we're looking at 6.25 milligram initial dose, and the usual dose is around 25 to 35 milligrams a day. Another antipsychotic you can consider is ziprasidone. For psychosis, you can also look at using a cholinesterase inhibitor if the person has comorbid dementia. And like when I mentioned around depression in the context of Parkinson's disease, where ECT is an option, ECT is also an option for treatment of psychosis in this group.
Cheryl, you mentioned impulse control disorder earlier on. I wonder if we can talk about this for a moment. So I understand it occurs in approximately 15% of patients who live with Parkinson's disease. So what are the most common behaviours seen, and how do we manage these behaviours?
So impulse control disorders in Parkinson's disease can exhibit as, pathological gambling, hypersexuality, compulsive shopping and eating. Impulse control disorders are about 2 to 3 times more common if the person's taking dopamine agonists. And these can develop, according to studies, in over 40% of people with Parkinson's disease after 5 years of dopamine agonist treatment. And there's a relationship to dose and duration of treatment. So how do you treat this? So the treatment of impulse control disorder in Parkinson's disease is to lower your dopaminergic medications. And, again, as I mentioned, adjusting Parkinson's meds can be challenging because these medications are needed to treat the movement symptoms for Parkinson's. Other strategies that have been mentioned in guidelines include adjusting in a Parkinson's treatment regime by switching your dopamine agonist to L-DOPA, or if they're already on L-DOPA, you can increase the dose of that.
Thinking sleep for a moment, sleep is often problematic and may be REM behavioural sleep disorder or insomnia. So what are the characteristics of REM behaviour sleep disorder? How do we investigate this and how do we manage it?
REM sleep behavior disorders is quite common. It occurs in about 50 to 60% of people with Parkinson's disease. It is actually considered one of the early signs of Parkinson's disease, and it can precede formal Parkinson's diagnosis by many years. REM sleep behavior disorder is characterized by loss of muscle paralysis or atonia during REM sleep, and the person can also experience vivid and unusually pleasant dreams at times. So how do you manage it? You can request a sleep study. Management strategies include establishing a safe environment during sleep. For example, removing sharp objects, patting corners of furniture, putting soft objects like pillows or cushions around the person in case the person falls out of bed while they're acting out. And if you're looking at medication options, there's clonazepam and melatonin that you can try.
And insomnia. So this may be episodic or chronic and is extremely common. So why is insomnia so common and how do we manage this?
So like you mentioned, it is common in Parkinson's disease, and it can be contributed by changes to Parkinson's medications, such as underdosing or weaning off of the L-DOPA, or some other medications like dopamine agonists. They can actually contribute to nightmares and vivid dreams. Your MAO-B inhibitors and amantadine, they can also worsen insomnia because they have alerting properties. So that wouldn't help the person in terms of their insomnia and moving forward. So with insomnia for Parkinson's, it usually presents with middle insomnia, poor sleep maintenance. And as you mentioned, it can be episodic or chronic. So chronic being that it lasts at least 3 nights a week for at least 3 months. So it's pretty significant. How do you manage the insomnia in Parkinson's? Make sure that the person has adequate treatment for their Parkinson's disease. You can look at using CBT, implementing sleep hygiene strategies. There's guidelines that mention use of light therapy, where it involves exposure to bright light. So that's light that is brighter than indoor light, but not as bright as direct sunlight. And using that 1 to 2 times a day for 30 to 60-minute blocks. And the advantages is that it's low cost and it's considered safe. Also, it's important to treat comorbid depression if this is present. And if you're looking at adding additional medications, there's melatonin and zopiclone that you can try.
Parkinson's dementia, Cheryl, this can also occur. I wonder how common an associated dementia is and what we need to consider in a primary care setting.
Parkinson's dementia is very common. And I was looking at the data prior to this talk, and it says there's up to 70 to 80% of people with Parkinson's who will develop dementia as part of the disease progression. The average time from onset of movement problems to development of dementia is about 10 years. So for primary care, I guess, do exclude organic causes. If someone presents with dementia, symptoms, cognitive impairment, and do review their medication regime, because you have medications that are prescribed for physical health issues and they have anticholinergic side effects, and this can worsen the person's cognitive functioning. You can also access specialist advice, for example, the mental health services for older adults in your district, whether cholinesterase inhibitors such as rivastigmine can help in this scenario.
Thank you, Cheryl. And to conclude our podcast today, your take-home messages, please, for our listeners.
The take-home messages, firstly, having that awareness that Parkinson's disease is a progressive neurological disorder, and it is associated with many mental health comorbidities that we've touched on today. Secondly, just be careful around medication management, as treatments for Parkinson's disease may exacerbate mental health issues, and likewise, treatment of mental health presentations can worsen Parkinson's disease symptoms. Thirdly, if seeing them in consult in your practice, exclude organic causes, for example, with depression and hypothyroidism, which commonly occurs in Parkinson's disease, and review the medication regime in case these are contributing to their presentation. And do liaise with neurology and specialist mental health for management advice, because this may need tweaking of their Parkinson's treatment regime or addition of psychotropic medications. And it may require multidisciplinary team input. So it is a team effort, and there needs to be collaboration across primary care and the different specialties.
Wonderful. Thank you, Cheryl. It's been a pleasure talking to you again today. If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll also find a list of resources used in this podcast on our website, goodfellowunit.org. Thank you for listening.